very excited to see you all, and hopefully you guys are excited too. So the first thing, hi guys, good evening. Can you all see me and hear me? Can you all see me and hear me, guys? Yeah, all right. So nice to see you all. Welcome to the much awaited crash course or the rapid revision course that you guys are waiting for. You want some backstory? You know what happened in the morning? I woke up with such a dangerous red eye. I don't know if you can make it out or not. I have like such a bad conjunctivitis since morning, and I was like, God, we've built this up so much, and now if I postpone this, I don't know what is going to happen. So somehow I've just gone through the day constantly applying antibiotics and ever fresh, and somehow I can just see barely on the screen right now. So thankfully, I mean, I could take this class. I was just thinking what to do. I mean, anyways, so that is what happened. So yeah, hopefully it'll be good by in a day or two. It'll take a day or two. Yeah, it's raining heavily here. So probably that's why my daughter's also down with viral. I have this, so lots going on. Anyways, right. So welcome to this. So very excited to see you all, and hopefully you guys are excited too. So the first thing that all of us are doing is we're all on the same page, that no matter when we are starting at what stage of preparation we are at, we are going to do this, right? So this is something wherein now we are literally in this together for the next 6 months. We're going to be doing all 19 subjects. We're going to be revising them. We're going to be doing BTR of that. So now it's a promise that all of you guys make me today, that you are going to give it your all, because I'm literally going out of my way and studying 19 subjects, and I don't have to, right? I have cleared my entrances. I have made a good enough career. So I am going out of my way literally for you guys. So this is something that you have to do and give it your best. See, this is a very good base. To be very honest and very frank, this is something that is very good for you to start off with, है ना? तो इसके ऊपर you can only be better, right? So make sure that you take 100% of what I am giving you, and then build up on it. Whatever resources you are following, solve MCQs, read as many notes as possible, so try and fill up all the lacuna, because I am doing the bulk work for you. So now you have to take this as a whole, give it your best, and then add up to, and make this the golden resource that you are doing. Okay, so that is something, that is a promise that all of you are making me, that you are going to give it your best shot now till your exam. Yes, this is going to be useful for INICT, FMG, as well as NEET, because we are doing the core topics, right? We are doing a rapid revision. I'm not teaching you details. Okay, so that is what we are going to be doing. So this is useful for everyone. Now I have posted a link here, that is the pinned link that all of you have clicked. One more life lesson, kabhi bhi aise random click link pe click nahi karna, है ना, unless you know what it is about. So that is something which is also one lesson, but ठीक है, अभी click किया है, so it's gonna be okay. So you will be redirected to a Telegram group. So that is the group that we'll be following from now on, right? I'll be posting all the PDFs there at least 30 minutes before the class, and I will also be, yeah, link is pinned. If you go to the pinned, ऊपर एकदम ही मेरा एक फोटो आ रहा है and side में link आ रहा है, click on that, है ना? तो उस पे click करोगे, that is the group, and every night we'll be doing one quiz on the subject जो भी हमने पढ़ा है, ठीक है? So I will keep you guys informed. Any revision, any resource that you want to share, any MCQ you want to share, you can do it there. I mean, it'll be like a good closed community wherein you can all interact with each other, and any rescheduling stuff, any information, resources, we can all do that on that group, है ना? So that is something which I wanted to say. Unable to join group, I don't know why some people are unable to join group. Maybe you can just DM me, है ना? अभी normal group join कर लो, radiology with Dr. Zainab Bora. बाकी मुझे DM कर दो, then we'll sort it out. Okay. Apart from that, now the other thing that I want to request all of you is, see, in 1.5 hours or in a total of 3 hours, we want to complete dermat, right? So that's a lot that we want to do, and I want to give you as much information as possible. So one request from all of you, जो भी doubts है, just save them towards the end, and do not ask me to repeat stuff unnecessarily, because usse kya hoga that we'll constantly be moving in circles, right? Now the best part about Unacademy is it is live and it's recorded. Once the class is over, in 30 minutes you'll get the recorded lecture, you'll get the PDF which is annotated and non annotated, है ना? तो you can see that if you have missed a point जो आपको लिखना रह गया है, or you can just see the class if you did not understand something, right? So that we can maintain the pace and do what we have intended to do, है ना? So that is one request. बाकी जो भी doubt है, save it till the end and ask me. Just कहीं पे note कर लो and then I will get back to you. ठीक है? तो ये है how it will be designed. You must have seen the PDF. We'll be doing the topics and end में we'll do all the previous year questions. Okay? Any other doubts that you have? एंड में, है ना, scheduling वाले. बाकी टेलीग्राम ग्रुप इज लिंक्ड ऑन द टॉप. एनीथिंग एल्स दैट यू वांट फ्रॉम मी इन द आउटसेट? एनीथिंग दैट यू वांट टू से और आस्क? नहीं? ठीक है. Don't worry, Aditi, है ना? I will teach whatever I feel is the most important for you all, है ना? So don't worry on that front. I will try and include everything which is possible. All right. So now let's begin. We are going to be starting from the basics and we'll build our way up from there. FMG से पहले finish नहीं होगा. मतलब 3 मॉड्यूल्स होंगे. चेक आउट द स्केड्यूल, यू विल गेट टू नो, है ना? तो स्केड्यूल एक बार देखो, ग्रुप पे लिखा हुआ है. आई विल पोस्ट इट अगेन. ऑलराइट, ओके. सो शुरू करते हैं. डोंट वरी अबाउट फर्स्ट एड एंड एवरीथिंग. व्हाटएवर इज useful for you I have added here itself. Okay, derma में first aid नहीं, first aid is only for step 1 which is useful for us, है ना? तो वो first second prof में ही relevant होगा, not for final year shots. ठीक है? Okay, so then let's begin. Yes, भगवान का नाम लेके शुरू करते हैं. Hopefully no network issues, no eye issues, no other issues, and we'll all begin and we'll all do very well in life and in NEET PG career. NEET PG तो बहुत छोटी सी बात है. Most importantly we'll all do well in life irrespective of how this rapid revision course goes, right? ठीक है, चलो फिर शुरू करते हैं. About basics. So these are the layers of the skin. Skin, as you know, is the biggest organ that we have, right? Something we study from biology. So skin has epidermis, dermis, subcutaneous fat. The outermost layer, which is the epidermis, is going to be composed of all of these layers. So very quickly, what is the lowermost layer? Easy. उसका नाम में ही base आता है. So this is the stratum basal. The topmost layer is corneum, right? So the topmost layer is stratum corneum. In between, how to remember? 3 layers. You remember LGS, legs याद रखेंगे. We all have legs. You remember legs. तो legs से क्या है? सबसे ऊपर lucidum. Lucidum is not present everywhere. Where is it present? Legs से याद रखेंगे. It's only present in palms and soles, right? It's not going to be present everywhere, but still it's a layer. फिर G, can you see these granules also here within the keratinocyte? So this is the stratum granulosum, and then S say this is spinosum, because all of these cells are going to be attached to one another through spinous processes. So these are the layers that we have in the epidermis. What are the cells in various layers? A few questions from each layer. So something which is constant everywhere, which is growing from the basal layer and then it's losing its nucleus and getting flattened and dying, are your keratinocytes, right? So keratinocytes are going to constitute 90% of the cells in the epidermis. Okay, apart from that, what are the 2 cells that you see here which start off with M in the basal layer? One has all of these dendritic processes. What is that cell? The one with dendritic processes is actually a melanocyte. Okay, so a melanocyte is what gives us pigment, which is the color that we have, isn't it? So now, is melanocyte basically going to, is there going to be a lot of melanocyte, or one melanocyte is going to give pigment to a lot of keratinocytes? Yes, one melanocyte will give pigment to how many keratinocytes? Yes, 36. तो इसको हम नाम देते हैं epidermal melanin unit, कि one melanocyte for 36 keratinocytes, है ना? तो उतनों को वो pigment देता है through melanosomes. So everywhere we have melanosomes, उसके कारण से we have this. So this is called as 1:36. So for every one melanosome we have 36 keratinocytes जो कि pigment मिल रहा है. All right, what is the other cell that we have? The other cell, which is this, which is your receptor, is your Merkel cell, right? You have heard Merkel cell carcinoma. That's a previous year AIMS question. So can you tell me the marker of this? This is what marker? CD? Is it CD, guys, or is it something else? You are all saying CD21. CD20 is for Langerhans cell, correct? This is cytokeratin, right? So this is going to be CK20 positive, right? And CK7, CK7 negative. So remember two cancers which are CK20 positive, CK7 negative, or just 20 positive. One is Merkel cell and what is the other one? Yeah, colon CA, right? So this is important from our INICET previous year question perspective, but right now just remember Merkel cell. So this is a slow adapting touch receptor. Okay, and remember it's in the basal cell. So whenever the epidermis goes down into the dermis, usko kya bolte hain? When epidermis goes down, that is called rete ridges, right? So in the rete ridges, remember हमारे पास होगा Merkel cell. ठीक है, so this is about that. Then you know one controversy, very famous controversy कि 2 point discrimination है, उसके लिए Merkel cell है या फिर Meissner cell है ना? तो उसका आंसर nobody knows, but according to me, because I follow Soumen Manna sir and this is what he has said through various references, it is going to be Merkel cell, right? So mark this as the one which is responsible for 2 point discrimination more than Meissner's, right? So Merkel more than Meissner. So do you agree in दोनों का बहुत there's a gehra rishta between both of them? Gehra rishta means a tight bond. For those of you who don't understand Hindi, and those of you who don't understand Hindi, we'll learn some Hindi also simultaneously. Okay, so there's some gehra rishta, right? There's a bond between them. So how is that bond? So like we saw कि जो नीचे आ रहा है, this is the epidermis which is going down. So these are rete ridges. So that way, do you agree? Dermis is also coming up. So what do we call that? We call that papilla, isn't it? That is your papillary dermis. Yesterday in Burns class, what did we study? कि अगर papillary dermis तक है, so that's a second degree superficial burn. And when it goes down, it is your reticular dermis, which is your second degree deep burn. So similarly, so this is your papillae. So now why gehra rishta? Gehra rishta because here we have seen that this is the basal layer. Here we have Merkel. And look who will come here. इसका nemesis. So what is the nemesis? Meissner, है ना? So ये है हमारा Meissner receptor. Understood? So now you can remember them together. And here also, who is on top? On top we have Merkel, right? So we have Merkel cells receptor which is in the epidermis anamica, and we have Meissner receptor which is in the dermis. Which dermis? Papillary dermis or papillae of the dermal layer, right? So that is why they are closely related. And you can also remember because Merkel is on top, in our answer also Merkel is on top, so that you don't mix them up. ठीक है, तो ये भी हमने कर लिया. Cool. So these are two receptors, two cells we have done. Then spinosum के बारे में what do you know? Spinosum, remember, is the thickest layer, right? So this is the thickest layer. Why spinosum? Why prickle layer? Because all of these keratinocytes are joined by intercellular processes which are called what? Desmosomes, right? So there are desmosomes here and there is calcium ATPase which is joining them. Now there are various kinds of desmosome proteins. So we have DSG which is desmoglein, we have DSC which is desmocolin, and we have DSP which is desmoplakin. पूरा पूरा याद मत रखो, desmoglein, desmocolin, desmoplakin. Very quickly tomorrow we will do the vesico-bullous disease, but remember whenever desmoglein के against antibody है, it is called what? It is pemphigus. It is your pemphigus vulgaris foliaceus. We will study that. Okay, so this is desmoglein. Whenever you have antibody against desmoplakin, P for plakin, P for paraneoplastic pemphigus. That is paraneoplastic pemphigus. ठीक है, तो PP से याद हो गया. Desmocolin, something that not a lot of people will know. Very good. That is subcorneal pustular dermatosis. That also I'll teach you tomorrow. उसमें ना hypopion sign मिलता है. There are pustules which form. Okay. I don't know why this has become black. I choose white only. Somehow this has become black. I can't change it now. I also don't like this, but it's okay. थोड़ा सा one today only. ठीक है. Desmoglein, desmoplakin, desmocolin. Okay, so this is about the three layers. The thing about black is it looks good while you are writing, but when retrospectively you see, no, it doesn't look very good. That is what I have learned from experience. Anyways, so this is spinosum, right? So this is your spinosum layer. इसमें ये सारे layers and what else? What is the cell that you have here in the spinosum layer? The one that you were saying, CD20, and that is your Langerhans cell. So very quickly, Langerhans cell histiocytosis. Tell me the markers. So here you will have what? CD20? No. Yes, you will have CD207, you will have S100, and you will have CD1A. है ना. So CD1A, 207, S100. These are the three cells that you have in Langerhans cell histiocytosis, where Langerhans cell are gonna increase. Langerhans cell का function क्या है? So these are your antigen presenting cells, right? So these are your antigen presenting cells, and very, very important, when you do their electron microscopy, you're gonna be seeing these tennis racket Burbeck granules. Very important question for everybody, right? So this is about your spinosome layer. Granulosome layer, as the name suggests, granulosome layer, it must be having granules, like you can see. क्या granules मिलते हैं यहाँ पे? The black pen has also disappeared. Yes, so you have two kinds of granules. One, you have keratohyalin granules. So keratohyalin granules eventually is going to form this filaggrin protein, right? So this is basically a filament aggregating protein. So filaggrin. My voice is not breaking, is it? Just refresh. I think it's just for you. You'll get annotated PDF. You'll get non-annotated. Both you will get. Okay. Once the class is over, will also get to see recorded version. So keratohyalin. What else? What are the other granules? The other granules are your lamellar granules, just means the bodies you are saying, Odland bodies are going to be there, right? So we have both of these, and Odland bodies is responsible for the moisture, right? So moisture ke liye Odland bodies are going to be responsible. So these are your two things here in granulosome. Lucidum khali palms and soles mein hai, and yahan pe just remember one thing, that you have these refractile granules of इलाडिन. ठीक है, इलाडिन के ग्रैन्यूल्स हैं लूसिडम में. लूसिडम, इलाडिन, काफी सिमिलर साउंडिंग नेम, एल एल ऐसा. ठीक है. एंड कॉर्नियम में क्या है? कॉर्नियम में बस यू हैव डेड केराटिनोसाइट्स व्हिच आर वेटिंग टू बी रिलीज्ड. यू हैव दीस फ्लैटेंड ए न्यूक्लिएट केराटिनोसाइट्स. सो नाउ कमिंग टू केराटिनोसाइट्स, वो यहाँ से बन के बेचारे ऊपर चढ़ रहे हैं, देन दे आर गेटिंग रिलीज्ड. सो इन हाउ मेनी डेज डज दिस एंटायर प्रोसेस अकर is called as epidermal turnover time, when they go from basal to corneum and then outside. That entire process, on an average, it's always a range, but the average is 56 days. So I just want you to remember 3 and 5. 56 days outside tak. Upar chadne tak it might take 28 days, but to be released it takes 56 days. So this is called as epidermal turnover time. So these are the two numbers. Can you remember 36 and 56 together? Yeah. So these are all the facts that we have for epidermis. Yeah, 28 plus 28. Okay, right. Now we go to the pathophysiology. So all of these are your a complete histopathological, complete derma path summarized in one slide. Derma path is supposedly difficult, right? Your entire path chapter of skin is very important, but everything is there on this one slide. So now, in the corneum, we can have four possible issues. One is parakeratosis. Parakeratosis kya tha? They were supposed to lose their nuclei, right? What if they retain the nucleus? That is called parakeratosis. Parakeratosis, the mnemonic is peas. Peas are very pyara, right? The mnemonic here is peas are very pyara. So para, pyara, peas. ठीक है? ऐसा you can remember? Okay. So what are all the disease? P for P hamesha psoriasis. Unless mentioned otherwise, P is gonna be PS is gonna be psoriasis. All right. Whenever I read PS, it's psoriasis. E for correct. E for eczema. Correct. फिर A for actinic keratosis. Two keratosis. Actinic keratosis and S से seborrheic keratosis. तो ये ना दो बहुत specific disease है. Whenever you hear the term keratosis, it means it is in the sun exposed area. Both of them are in the sun exposed area. Okay, so इनको अभी निपटा दे. Just one point you have to remember. So what is this? Can you see one cutaneous horn here? Yes. So cutaneous horn देखा. What is the diagnosis here? Yes, this is actinic keratosis. This is not seborrheic keratosis. A lot of you are saying squamous cell carcinoma for pre-malignancy. Yeah, so this is going to be pre-malignant, but abhi usko bhul jao. We'll study squamous cell tomorrow. And are you saying that yahan pe squamous bhi aata hai? Yes. Fine. There also you will have parakeratosis. Okay. So this is cutaneous horn where you have actinic keratosis. One word, one buzzword about this. And seborrheic keratitis, what do you want to remember? One, each of them individually are gonna have a feature which is called, it looks stuck on, ऐसा लगता है कि stuck on है, ऐसा stuck on picture है. So one, they will be in the sun exposed area, but when you see कि बहुत सारे multiple seborrheic keratitis, very nice, that is called as sign of lesser trellat. And sign of lesser trellat basically means that you have an underlying malignancy. Usually there's going to be a GI adenocarcinoma that you will find. So this is a paraneoplastic syndrome where you have multiple seborrheic keratitis or keratosis. All right. So these are the two questions that you get. USMLE में questions बहुत आते हैं. All right. So these are also, these diseases also we have done. Malignancy हम कल करेंगे. ठीक है. So this is about parakeratosis. Then we go to hyperkeratosis. So how we remember PAL is, you have friends, right? PAL means friends. So your friends were very hyper, है ना? Hyper friends सबके पास होते हैं. So hyper is PAL. So PAL से क्या याद रखेंगे? P for always psoriasis. A for, this is interesting. So A is not, A is a misnomer actually. So A is basically, seborrheic dermatitis and keratosis are, yes, definitely different. Okay, so seborrheic dermatitis कल बता दूंगी फटाफट, but they are completely different. Seborrheic dermatitis, always you'll have these yellow scaly things, all right, but that is completely different. Okay, right. So A is actually acanthosis nigricans. So literally acanthosis nigricans means that the spinous layer is thickened, right? But here actually it's a misnomer wherein acanthosis actually has a corneum layer which is thickened. Okay, तो ये इंटरेस्टिंग है, ये याद रखना है. Acanthosis nigricans, what will be the typical history? There will be an obese patient, PCOD का history होगा, and you'll have these blackish, diabetes का history होगा, you'll have these blackish pigment velvety lesions in the axilla, in the intertriginous areas, right? So that'll be the history, correct? Any obese patient with metabolic syndrome, or even can this also be a paraneoplastic syndrome where there's a sign of internal malignancy? Yes, this also. So we've covered acanthosis, black velvety lesions milenge, we will diagnose this. It is hyperkeratosis. Remember, this is a misnomer. So AIMS can actually trick you on this. L से क्या है? L, anywhere you see L, it is lichen planus. Okay, so lichen planus is hyper. So orthokeratosis is what? Very simple. Anytime you have hyper, but you don't have para. So can I say typically lichen planus is one which had hyper but did not have para. So it is lichen planus. Easy. Dyskeratosis क्या है? Even though we've placed it here because the name is keratosis, but dyskeratosis is actually abnormal keratinization below granular layer. So when we see कि granular layer के नीचे keratinization is not proper, that is called as dyskeratosis. Here you want to remember all 4 diseases. What all 4 diseases? 2 के group में. एक तो हो गया Darier's and Hailey-Hailey. कल ये दोनों diseases पढ़ेंगे. Darier, Hailey-Hailey as a group. I will try and go a bit slower, but I want to complete more. The recorded lecture will be available. Okay, so you can see if you are if you feel it's too fast. Darrier and Hailey-Hailey. Apart from, but I'll try to keep the pace moderate, है ना? बहुत नहीं भगाऊंगी. अभी तक बहुत भगा रही हूँ ऐसा तो नहीं लग रहा ना? अभी तो because we are accumulating everything, इसलिए नया नया अचानक से too much information, but towards the end you will feel अच्छा ये सब तो पढ़ा हुआ है, that's why. ठीक है, Darrier, Hailey-Hailey, and then you have 2 diseases which is Bowen and squamous cell disease. So pre-malignant carcinoma in situ is Bowen disease and this is squamous cell carcinoma. ठीक है, so this is about our dyskeratosis. So these are all your corneal layer. ठीक है, चलो अब जाते हैं ग्रैन्युलर लेयर पे. ग्रैन्युलर लेयर, ए ग्रैनुलोसिस समझ में आ रहा है बच्चों? ए ग्रैनुलोसिस मींस कि ग्रैन्युलर लेयर है ही नहीं. सो नाउ व्हिच वाज द डिजीज जो हर जगह पे ऑलरेडी घुस रहा था? पैरा में भी, हाइपर में भी, सोरियासिस. सोरियासिस से तुम्हें ग्रैन्युलर लेयर नहीं देंगे. सो ए ग्रैनुलोसिस तुम्हें सब नहीं मिल सकता, राइट? सो सोरियासिस इज ए ग्रैनुलोसिस. अब बेचारा लाइकन प्लेनस वाज नॉट गेटिंग पैरा, राइट? सो वी सेड लाइकन प्लेनस, हैंड राइटिंग हाँ थोड़ा बेटर कर सकती हूँ. हाइपर ग्रैनुलोसिस तुम्हें देंगे, ठीक है? सो लाइकन प्लानस इज योर हाइपर ग्रैनुलोसिस. एंड रिमेंबर दिस इज रिस्पॉन्सिबल फॉर द व्हाइटिश स्ट्राया विच इज कॉल्ड एज विकहैम स्ट्राया ऑन द लाइकन प्लेनस लीजन. लाइकन प्लानस का पता है ना, पर्पल लीजन होते हैं, उसके ऊपर व्हाइट स्ट्राया जो मिलते हैं. द हिस्टोपैथोलॉजिकल बेसिस बिहाइंड दैट इज एक्चुअली हाइपर ग्रैनुलोसिस. ओके, सो रिमेंबर दैट. ठीक है, सोरियासिस में ए ग्रैनुलोसिस, ओके, नॉट हाइपो बोल सकते हो, ए बेसिकली नहीं है. ओके, फिलैग्रिन एंटीबॉडी, रिमेंबर ग्रैन्युलर लेयर हैड फिलैग्रिन इन द ग्रैन्यूल्स, केराटोहाइलिन ग्रैन्यूल्स. अगर इसके अगेंस्ट एंटीबॉडी है, वी विल हैव इक्थायोसिस, फिश नेट स्केल्स मिलेंगे उसमें. एंड ऑडलैंड बॉडीज, रिमेंबर ऑडलैंड बॉडीज इन द लैमेलर ग्रैन्यूल्स which were providing moisture. So if moisture is not there, I will have an eczema which is called asteatotic eczema, जो usually winters में होगा, right? So because moisture layer is not there, dry skin, so asteatotic eczema. Understood? Odland body, yes, is a normal finding. They are in the lamellar granules. Okay, so this is about the granules. फिर spinous layer, acanthosis means spinous layer is thickened. So again, what will come in? जो हर जगह पे घुस रहा है, right? Everything is gonna be psoriasis except for granular layer. Psoriasis has everything which is thickened. Acantholysis though, when you have acantholysis, all your desmosomes are going because of the antibodies. Correct. This is gonna be pemphigus. Okay, so this is all your pemphigus which we'll study tomorrow. Now we have spongiosis and ballooning degeneration. Both of them are your edema. Spongiosis is intercellular edema or intracellular edema? Intercellular, right? So in between you have intercellular edema, which is seen in eczema. This is seen in acute eczema. On the other hand, when you have intracellular, cell is becoming ballooned out because of intracellular edema. This I'm sure all of you know is herpes simplex virus, which has ballooning cytopathic effect, right? Okay. Then we go to basal cell. Basal cell degenerate ho gaya. So where is this typically seen? This is typically a finding of lichen planus. Apart from that, this can also be seen in discoid lupus erythematosus and lupus vulgaris, but this is not very important. Just remember lichen planus has basal cell degeneration. Okay, and because of this basal cell degeneration only, you will have an empty space in lichen planus. What is that empty space called separating dermis and epidermis? Yes, that is called as Max Joseph space. ये सब कुछ हम फिर से रिवाइज करेंगे. Max Joseph space, and that is why you also have these apoptotic bodies. जो भी cell degenerate हुए, they'll fall in the apoptotic bodies, which are called as, yeah, civet bodies, right? So civet bodies or colloid bodies are basically the same thing. So with the same concept, you can actually remember all of these. And in this layer, you have this K5 by 14, which is connecting the dermis to the epidermis. When this has antibodies against them, this is going to be epidermolysis bullosa simplex, EBS, which I will also talk about tomorrow. So this is a whole summary of the entire dermatopath, and now we are going to be revisiting everything. Okay. Yes. No, this is not CK. This is your keratin protein, K5 by 14. Okay, so this is something which we are going to be doing again. Okay, so this is orthokeratosis is where you have hyperkeratosis but no parakeratosis. So just thickening without retention of nucleus. All right. Okay, this we have done. Now we have a few micro abscesses. So we can have neutrophilic micro abscesses. Three things. The buzzword papillary tip microabscess, multiple times asked question. The moment you hear this, you want to think of DH, dermatitis herpetiformis, associated with what disease? इसमें पूछेंगे underlying क्या rule out करोगे? Celiac disease. So in a patient of celiac disease, when you have extensor surface पे very itchy pruritic papillary region, dermatitis herpetiformis. Then you have Munro's microabscess. This is there in the corneum layer. Munro's microabscess are seen with psoriasis. And one more, Kojok's pustules. Kojok's pustules are seen in the spinous layer and also seen where? Also in psoriasis. So psoriasis will have two kinds of abscesses. Corneum layer पे तो Munro और नीचे है Kojok pustule तो spinosum. Okay. Lymphocytic microabscess कौन से होते हैं? These are your Potrier's microabscesses. Can you tell me where we see them? Yeah, so you can remember M and P here. यहाँ पे P goes फिर mycosis fungoides, right? So P and M stick together. Mycosis fungoides, which is your cutaneous T cell lymphoma. Sézari's disease is your hematogenous version of cutaneous T cell lymphoma, right? So this is seen only in cutaneous T cell lymphoma. Sézary is when this becomes hematogenous. So उसमें कैसा cerebriform nucleus मिलता है, right? So that is your cerebriform appearance. So this is Potrier's. Eosinophilic microabscesses कहाँ मिलेंगे? Just one rare thing, very nice Pavani. This is seen in P vegetans. Okay, so कल बात करेंगे इसके बारे में. P vegetans, just one feature. Very nice. So we have everything down from path, right? So these are all questions which are going to be asked a lot of time. Good, Aditi. Erythema toxicum, but these are not micro abscesses. I'll tell you. Good point, good relation कि उसमें eosinophils मिलते हैं, but we'll get to it. Now epidermis is sorted for everybody. Epidermis and all of its pathological feature. तो डर्मा तो हमारा हो ही गया आधा. Now we go to dermis. So in the dermis, like we said, papillary dermis है जिसमें what do we have? Meissner or Merkel? जिसमें we have Meissner, right? तो Merkel तो नीचे था, यहाँ पे we have Meissner, and then you have your reticular dermis, and then you go down, you have your subcutaneous fat. So dermis के layers हो गए. One more thing about dermis is here you have two collagen. You have type 1 and you have type 3 collagen. One of the NEET PG exams, you had a very irritating question on the ratio of them. Can you tell me the ratio of them? So type 1 is going to be 4:1, right? Is it 8:1? Have you read 8:1? I have read 4:1. It is not 3:1. Just remember, actually in NEET PG exam, the question was, is it 3:1? Answer was wrong. It is not 3:1. So it's anything more than that. So remember 4 to 8:1 probably. Maybe we can confirm tomorrow. What I read was 4:1. Okay. But just confirm. ठीक है. Fine. So 4:1 or 8:1, it's not 3:1. Just remember that. So यहाँ पे ये collagen है. इसके अलावा what else? Right. Now when you go to the fat layer, you have inflammation of fat, which is called what? जब भी fat inflame हो जाएगा, we call it paniculitis. You have two kinds of paniculitis. One is septal paniculitis. Another one is lobular paniculitis. So prototype of septal paniculitis is a disease called, very very important, erythema nodosum, and lobular ka prototype is one very rare disease which is called erythema induratum. All right, it is also called as erythema induratum of Bazin. Right. So now do you want to do all of these confusing erythemas together? साथ साथ कर लेते हैं. There's no disturbance. Janvi, you refresh. I think आपके नेट में प्रॉब्लम है शायद, है ना? Is that why you are saying yes, that you want to do them together and not because you have disturbance? हाँ, ठीक है. So we have these two erythemas which are your paniculitis. Okay, so these are your paniculitis. So when you see shin में lesions, this is the image you will always get. This is your Commons Creative License image, so from Google. So this is erythema nodosum. Which are they painful? Obviously, you have paniculitis. These are going to be painful. These are going to be tender. Are they going to be pruritic? No, no pruritis here. There is no pruritis here. So erythema nodosum, shin pe painful, tender, nodular lesion seen in a lot of diseases. So सबसे पहले infections. I'll tell you. Infection में क्या है erythema nodosum में? What are the infections that you want to remember here? Yes, one is strep. The other one, which always comes in our life, tuberculosis. So strep and TB. Then you have various connective tissue disorder. Very important. Remember sarcoidosis. Remember Behçet's disease. And you also have association with IBD, right? As you are all saying, inflammatory bowel disease has association with this. And anything else that you want to remember? Sometimes with drugs also this can be related. Yes, also related to pregnancy, also related to OCPs. Okay. Yes, type 2 lepra is erythema nodosum leprae. Correct. Yeah, that also you can remember. Okay, so these are all the conditions of erythema nodosum. Sulfa drugs. Cool. Right. On the other hand, when you see that they actually ulcerate, they are not nodular, they are ulcerating. This becomes what? No mnemonic you need to remember just randomly, because nobody will ask list all causes of erythema nodosum, right? So I don't believe in mnemonics like this, क्योंकि कोई पूछने थोड़ी वाला है बताओ सारे causes. They will give you three and they'll give you odd one out. So you know, ऐसे में I will just recommend कि mnemonics बनाओ भी मत, because in the exam you will forget. And what they will do is they'll give you a same letter ka thing which is fitting in your mnemonic, and then you will be like अरे S तो यही था, and then you'll forget, है ना? So that's why remember specific. Okay. Sarcoid के बाद Behçet's disease. We'll talk about Behçet's. So this is ulcerative. So this is erythema induratum of Bazin. So this is a hypersensitivity reaction to tuberculosis. हम देखेंगे hypersensitivity reaction on TB. So this is about that. So this is your septal paniculitis. This is lobular paniculitis. So that is done. Other erythema. So which is this? Which is evanescent. This is your evanescent, which means it appears and it goes. It is non-pruritic. So tell me this and its association. Is it? Yeah. So is it erythema migrans? Is it erythema marginatum? Is it erythema multiforme? There are three EMs on this same slide. Correct. This is erythema marginatum. Why? How to remember? So we marginate people who have rheumatic heart disease, right? We are going to keep them aside in society because we need to give them antibiotics, right? So remember, they are marginated from the general population. So this is rheumatic heart disease. So this is evanescent non-pruritic, and yes, one of you correctly said it worsens with heat. Yeah, so if you apply heat for certain reason, it will actually worsen. Okay, very prototype. Now two true target lesions. Both of these are your true target lesions. So you have this center, then you have periphery. So this is target. This you cannot get wrong in exam. This is your 100 type question. 100 type question means ये आपको सही करना ही है. Erythema multiforme bullseye lesion. Tell me the causative things. First of all, bullseye in the fundus, what does that remind you of? That reminds you of which drug? Yeah, that reminds you of chloroquine. So remember, chloroquine is also implicated here. So this is where chloroquine comes in both. You have target or bullseye in the eye also. You have hydroxychloroquine or chloroquine in the skin also. So both of them are going to be chloroquine. Apart from that, you can have NSAIDs which come in here, sulfa drugs which cause this, right? Most importantly, infections. The one infection that you will always top the list here, HSV. So do not confuse this with erythema nodosum. यहाँ पे bacteria है, strep and TB. Here you have HSV, you have mycoplasma which come in, right? So two infections. Do not mix them up. Very important. I've seen people do that कि HSV erythema nodosum में डाल देते हैं. So this is the infection. You have drugs which are very important. Yeah, and connective tissue disorders also you can remember, but this two categories very important. And finally, what is this one more target lesion? This is your erythema migrans, and you want to rule out Lyme's disease, right? So this is where you want to rule out a tick bite and Lyme's disease, not very common in our country though. So these are all of our erythematous lesions. No, two more. What is this where you have very pattern sort of an appearance? This is erythema gyratum repens, right? इसमें क्या रूल आउट करना है? जस्ट वन वर्ड, रूल आउट अंडरलाइंग जीआई मैलिग्नेंसी, और जस्ट रूल आउट अंडरलाइंग adenosine. So this is also paraneoplastic syndrome. What you said, one of you also mentioned one more erythema here. Erythema, necrolytic migratory erythema. Yeah, so where do you see anemia? Where you will have necrosis. Necrolytic migratory erythema, I will teach you probably sometime else. This is seen in glucagonoma. Yeah, bhi kar lo. So this is in glucagonoma, right? So this is different. Okay, necrolytic migratory erythema. Here they'll give you some sort of other features of glucagonoma. All right, like maybe diabetes mellitus, 4Ds होते हैं ना, ये सब देंगे. What do you have here when you have a neonate? This is erythema toxicum neonatorum. So this is a finding that can happen at birth and you will be scared, right? Necrolytic migratory erythema. ठीक है? That is about anemia. Erythema toxicum neonatorum. Yes. So this is a happy finding. बच्चे को chill करो कि कुछ नहीं होगा तुम्हें. And yes, when you see the cells, now you will see eosinophils, right? What I think Aditi was saying. So this is eosinophil. So ये बस reassure करना, ये हमेशा image देंगे and you will be scared ना कि अरे is it scalded skin syndrome? Is it 10? You know what is it? But you just say it is normal. Okay, you will see eosinophils here. साथ में on day 2 you also see if you see a very pustular sort of lesion. So you can also see neonatal pustular dermatosis, right? So that is also neonatal pustular dermatosis. So as the name suggests, इसमें क्या cells मिलेंगे? You will see neutrophils, right? So if you see pustular cells in a newborn, again, do we have to reassure these babies also? Yeah, reassure them also. उनको भी कुछ नहीं होगा. So yes, neonatal pustular dermatosis. Cool. So this is about erythemas, annular lesions, that is done. Okay, erythema infectiosum, we'll get to it. Peds mein padenge. So now you have hair cycle, all the exanthems. Okay, so you have hair cycle phases. What are the three phases? Very quickly. Remember ACT, ACT. So you have anagen, you have catagen, you have telogen. So anagen is when your hair is in the longest phase. So this is average 3 years. 3 years tak aap anagen mein ho. Then it goes into catagen. 3 years ke baad the hair is tired. So now it wants to slowly die. So it gives its notice period. Whenever you want to leave something, you'll give a notice period, which in this case is 3 weeks. And uska notice period that all right, let's just stay chill. And finally, when it dies, telogen. What is how much is that time? That is 3 months. Okay, so years, weeks, and months. Remember, this is not aisa. serial order में नहीं है. So you can remember alphabetically. ACT is alphabetical. Y, W and M is also in alphabetical order, right? From Y to M, right? So ऐसे करके ये तीन याद रखो. Now there are two things you want to know: anagen effluvium and telogen effluvium, right? So here they'll give you very very typical history. So anagen effluvium में क्या होगा? It will be post chemo. So if they tell you post chemotherapy hair loss is happening, diagnosis is anagen effluvium. But if they give you a very very typical timeline that after 3 months of any acute stress or after pregnancy, postpartum hair loss होता है, right? It is very real. In fact, it happens strictly on a timeline. I remember from my pregnant postpartum period, at 3 months you suddenly start to have a lot of hair loss, you know. So this is definitely there. So this is not a myth, this is a true disorder. So this is telogen effluvium. So yeah, after NEET PG also 3 months. फिर कुछ नहीं. So can you do anything about this? What do you do for these patients? कुछ नहीं, चिल मारो ना, नए एनाजन के हेयर आ जाएंगे मेरे आगे वापस. तो कुछ नहीं, टेंशन नहीं लेना. This is telogen effluvium, right? So normal process. These are all physiological process. You can't do anything about it. I mean, you can do like people say, Mama Earth ka wo onion wala wo laga lo and stuff, but it doesn't really help so much. So that's more of promotion only. But that's why, you know, you have to tell these guys that these things will not help because it's a normal process. It's telogen effluvium, right? I also tried it being doctor, knowing everything. I still tried it, but I mean, doesn't really. Okay, so anyway, so this is stress and pregnancy. So this is about that. Then you have two kind. Then you have androgenetic alopecia. So what does that tell you? That this is because of androgen. So the hormone which is responsible is dihydrotestosterone, right? So this is DHT induced hair loss. This can be of two pattern. Drug induced be chemotherapy, I guess. So this anogenic fluid. All right, right. So two kinds of, obviously देख के पता लग रहा है. So this is male. I don't know why I hid this. So this is male pattern baldness, right? So where does male pattern or Hamilton pattern baldness baldness happen? So it is going to happen when the frontal line keeps receding. Can you see कि यहाँ से गए फिर यहाँ पे? So it's basically a frontal pattern baldness. Okay. HID what? What HID? No, this is DHT. Okay. And second one is your female pattern. So they can give you these images. So this is your female pattern baldness, which is also called as Ludwig pattern, wherein जो हमारा ये है center parting area, there it becomes wider and wider. So at the site of parting, you will have more loss. Okay. So what can you do for this? So topically, a lot of people also take it is minoxidil, right? So this is the front line treatment, first line treatment. But secondly, if I have DHT to blame, can I block DHT in systemic form? What can I do? Yes, I can give finasteride, right? So na rahega DHT, na rahega hair loss. So that is what we do. So minoxidil is first line, followed by finasteride is what we can do for androgenetic alopecia. So far we are all in your non-scarring, normal alopecia and a non-scarring alopecia. No, this is not used for females, only in males. Okay, so this is about, or Mama Earth. If all fails, you can go for Mama Earth onion shampoo or whatever. Okay, next, very very important. What do you have? Yeah, in females also DHT is responsible. Very important. We have alopecia areata. Okay, alopecia areata is what we have. So alopecia areata, again, you'll have this patchy hair loss, which is non-scarring. What is the other sign you will find here? Yes, this is an autoimmune disorder. So this is going to be, there are going to be lymphocytes which are doing this autoimmune. So there are one exclamatory hair sign. So physical examination sign is going to be exclamation hair sign. What does that mean? So normally we have hair जो कि नीचे से मोटे हैं, then they taper, right? But what's going to happen here is you have ulta. So basically where the hair loss is happening, there's going to be tapering here at the bulb and then it becomes wider. So this is called as exclamation hair sign. And the other sign that one of you said is going white overnight. So what does that mean? So basically what will happen is that this alopecia tends to do what? It tends to spare the white hairs. It spares the gray hair and the white hair. So what will happen? Because everything else is going, only the white would be spared. So this I mean, it will look like you have gone white overnight, whereas you've just gone bald overnight. Just your white hair are spared, है ना? तो ये हो गया. So this is that. What do you see in histopath that all of you are telling me? So in histopath, we are no, there won't be any perifollicular hemorrhage, but what would there be? What do you see around the follicles? Do you see a lot of lymphocytes because it's inflammation, right? So you're gonna be seeing a lot of peribulbar lymphocytic infiltration or inflammation, which is gonna be called as a swarm of bees sign. Very nice. All of you guys know everything, no? Lymphocytic infiltration, which is swarm of bee sign. What else do you see in the nails? Nails में अपने को मिलेगा pitting. What kind of pitting? Is it gonna be very geometrical, regular pitting? Yes, very, very geometric, very, very regular pitting. Unlike what disease where you have very irregular pitting, oil drop भी मिलेगा, psoriasis, right? So psoriasis will have irregular, here you will have regular. A few terms that I thought you might want to know. Alopecia totalis, you will have almost complete hair loss. Alopecia universalis, universal, पूरे body में. Ophiasis is along the scalp margin. So along the margin, it will form an O, isn't it? अगर हम margin से करेंगे, it forms an O. So that is why ophiasis. Sisypho pattern spares the side. So surface spares, है ना? तो surface याद रखो spares, it spares the side. All right, ऐसे याद रख लोगे. So O is when you have this O margin, S is when it spares the side and the back. So just ये दोनों में they can ask you as a confusion. Okay, right? So this is about alopecia areata. Then we have two more types of non-scarring alopecia. When you see something like this, different lengths, I'll give you a few buzzwords. So there are different lengths of the hair. Secondly, you are finding hair loss in very accessible area, जहाँ पे आप touch कर सकते हो. So very accessible areas is having hair loss. Thirdly, you are finding some perifollicular hemorrhage that one of you was asking, ma'am, perifollicular hemorrhage thoda aa raha hai. Means somebody must be pulling it, right? So correct. This is your psychiatric disorder, which is trichotillomania. So this is trichotillomania. And what is the radiological counterpart? What will you see in the stomach if the person is eating those hair also? That will be your trichobezoar, right? So that is trichobezoar. So दोनों का association मिल सकता है. And if that bezoar is so long that it reaches the ileum, small bowel, that is called as Rapunzel syndrome. That is called as Rapunzel syndrome. Rapunzel जितना बड़ा सा hair you are going into the small bowel, causing small bowel obstruction. Yes, there is also one more sign which is called as Friar Truck sign. All right, so this is name of one person. So this is called Friar Truck sign, which is also seen in trichotillomania. All right, and what is this? Very important image based question. If I tell you this person had genital ulcer which he ignored, good. This is moth-eaten alopecia, which is seen with secondary syphilis, right? So again, very patchy, non-scarring alopecia. So far everything we've done is non-scarring. Do not even try to make mnemonics to remember the list of non-scarring, because we'll just remember three things which are scarring जो आपको exam में पूछेंगे. What are the three things which cause scarring alopecia? Most important, which I have given you image. DLE, discoid lupus erythematosus, very important. So सबसे पहले इसी को पढ़ लेते हैं, या first tell me two other things. One is going to be tinea capitis. Now tinea capitis, remember, can be scarring also, can be non-scarring also. But what is typically scarring is your chirion and scutula, जो हम पढ़ेंगे, ठीक है? Chirion and favus, which has scutula, we will study, which is typically scarring. And the other disease which is very typically scarring alopecia is going to be lichen planus. Remember this. So these are your three things only which you have to remember. Everything else is going to be non-scarring. Okay, right? So DLE पढ़ लेते हैं फटाफट. So one, you are seeing that this is scarring alopecia. Okay, so this is how it will produce scar, and it is irreversible. Then what do you have here? So how does DLE look like? We'll finish it here only. So you will see this lesion with this central depigmentation, right? So you will see the central depigmentation, flattened, cleared, sort of discoid lesions, and one very disgusting looking sign. If you actually look at the tongue of a cat, this is also called as a cat tongue sign. Or if you actually look at the carpet, so this is also called as carpet tack sign or cat tongue sign, basically because of the spinous process, and that is because of these scales. When you look at these lesions, you will find that there are all of these uh, scales on the undersurface of the lesions, right? So because of this has also been given cat tongue or carpet tacking sign because of follicular plugging. Alright, so ये सारा कुछ है जो आपको DLE में याद रखना है. Okay, so this is the tongue, this is not the actual DLE lesion, this is DLE lesion. ठीक है, तो ये तीन चीजें on DLE you want to remember, and it causes scarring alopecia. When we talk about tinea, or basically two things which are asked in exam, I will give you the buzzword. So if they tell that in a child you have these painful boggy lesions with associated lymph nodes, what are you going to say? You're going to say Kirion. And what is the most common causative agent? Trichophyton mentagrophytes, right? So you want to remember Trichophyton mentagrophyte here. On the other hand, when you see this cup-shaped scutula literally means cup-shaped. So this is going to be your favus. So basically you will see this crusting, you will see scutula, and the organism here is T. Sean-Laney. So just remember S sticking together. Sean-Laney, scutula में C से crusting. So this is your favus. Okay, so this is all that you wanna remember. Drug of choice for tinea capitis, yeah, this is in adults. Can be seen in child also. So specific nahi hai, but this is more common in child. Yeah, the drug of choice for tinea capitis in general is gonna be griseofulvin, right? So you wanna remember that right here. Okay, so this is about dermatophytes. Everything else of dermatophytes, no, we'll study with micro only. ठीक है, जब mycology करेंगे, but this is very derma specific. Done. And when you look at nails now, nails में ये क्या होगा? So whenever you see कि subungual, is this subungual below the nail? Yeah. So whenever you see the subungual proliferation, this can be two things. If there is pain, there is inflammation, this will be subungual onychomycosis, right? So onychomycosis, subungual onychomycosis is what this is. Apart from that, this can also be subungual hyperkeratosis, which is associated with what? Yes, which is associated with not lichen planus but psoriasis. So whenever you see such a picture, I want you to think of two things. It could be psoriasis, where this could represent hyperkeratosis, or it could represent the most common type of subungual onychomycosis, which is what? Which is DLSO. So DLSO is basically when you have your lateral and distal subungual onychomycosis, right? So this is the most common form. Distal, so if this is the nail, right? So ye wala nail, and this is the finger. So ye wala part is distal, and then you have lateral, and then you have subungual, nail bed getting involved. So that is why DLSO is most common. Okay, so this is about nail. Shall we go into sweat glands quickly? We have two kinds of sweat glands. Are you guys okay so far? 49 minutes, I didn't even realize कि 49 minutes हो गए. Is this the same with you? फटाफट time जा रहा है. How will we finish? We are on 25th slide out of 80. Anyways, we'll finish. Yeah, for sure. This is enough for FMG. Just supplement it with questions, okay? Right. So sweat glands can be eccrine and बस इसके बाद MCQs कर लो. For most subjects, it would be enough. जब बड़े subjects we won't have enough time, I'll tell you what all to do. Okay, so sweat glands, you have eccrine and you have apocrine. So as the name suggests, eccrine, remember, are seen everywhere. E for everywhere, E for eccrine, whereas A is going to be seen wherever you have axilla or you have groin, right? So these are the areas where you're going to have apocrine glands. What else? This is going to be controlled. C hai yahan pe. This is going to be cholinergic system ke control mein. A for adrenergic system ke control mein, right? So this is what we have. What else? The diseases. So whenever eccrine glands get blocked, because they are everywhere, in the back आपके पास ये चीजें मिलेगी. End में पूछना अर्जुन एक बार. You will have all of these everywhere. You will have these follicular things which are there. ये आपने देखा होगा ना, prickly heat जिसको बोलते हैं. चुपती गर्मी का मौसम वाला rhyme. So this is prickly heat, not rhyme but jingle. Yeah, rhyme. So this prickly heat, which is also called as malaria. Yeah, so this is something which happens. Yeah, dermicool. So this is something which happens in a lot of humid, hot weather. Yeah, so this is prickly heat and malaria जो आपने देखा होगा, ठंडा ठंडा cool बिल्कुल. Apocrine, obviously क्या system दिया होगा? You will be given axilla, right? So no, this is not rubra. What is this? This is very, very important. When all the apocrine glands are blocked, this is going to be very important. Fox Fordyce disease. So when you see these glands coming as these vesicle छोटू dots, this is Fox Fordyce disease. And इसको किससे confuse नहीं करना बच्चों? This is not to be confused with Fordyce spots. Okay, Fordyce spots. these are seen where? These are seen in lips, right? So these are your ectopic sebaceous glands which are there in the lips. Okay, and if they become sinuses, they become nodules, they become thickened, what is this called? This is called hidradenitis suppurata, है ना? So this can also be a potential question. So axilla देख के they can ask you acanthosis nigricans if it is black. If there are sinuses, this is a repeat aims question. Hidradenitis suppurata. If you find these chota chota lesions, Foxfordyce disease, very very important. Okay, and I'll show you some more. Fine. Apart from that, ये basic तो बताया ही नहीं. What is eccrine? What is apocrine? So eccrine glands are going to open directly, whereas apocrine are going to open into a hair follicle, right? And that is why this is in axilla and groin. Okay. ठीक है, so this is about that. इसमें कुछ खास treatment, wherever treatment is important I'll tell you, otherwise we don't have to go into everything, otherwise how will we finish? Okay, so wherever it's been asked I will tell you. ठीक है, so this is about that. Two very very important diseases and two mimics also. So this is how questions are asked. You need to know differentials, right? Rather than knowing everything, हमें बस यही करना है क्या important है. Types of malaria you can do if you want, not never been asked. So which is rosacea, which is SLE? Two mimics. So this is rosacea. So few words about rosacea. What is going to happen? Are these constant? Are these fixed, or they're going to increase with flushing? They're going to increase with flushing whenever you have stress, whenever you have um, any sort of hot spicy food, है ना, sunlight पे. So this is going to be increasing, decreasing, increases with, and they're going to flush. Apart from that, we always look at this. Look at the nasolabial folds. So here nasolabial folds are involved. You will see telangiectasias, reddening, ये सब. Whereas when you see कि nasolabial fold is spared, very very important. This is SLE. Nasolabial fold is spared. नाम में है SLE, नाम में है spared. All right, never ever forget this. And they are gonna be fixed. Will they change with spicy food, hot food? No, no, they are gonna be fixed. And you will have associated symptoms of SLE also, dopamine rash. Okay, so this is about SLE versus rosacea. Acne पे आजकल सवाल तो कहाँ ही आते हैं, but very easy, right? So you have 4 grades of acne. What is the earliest finding in grade 1 that you have? What are all of these? These are gonna be comedones, right? So open, close, black, white, comedones. After that, in the second lesion, what will you have? Now you're going to have papular lesions, right? You'll have papules. In type 3, they're going to become pustules, right? Papulopustular region. And type 4, you're going to have this very cystic nodulosystemic lesions, right? Nodulocystic lesions. हाँ बिल्कुल. तो इसीलिए rapid revision is best ना, कि जो जो आ रहा है वही पढ़ो. This is nodulocystic, right? So treatment फटाफट फटाफट कर लेते हैं. First stage में हम क्या देंगे? We are only gonna give topical retinoids, है ना? तो adapalene वगैरह creams, you guys know. So this is topical retinoids. इसमें क्या करेंगे? So we keep adding. So TR topical retinoids के साथ हम डालेंगे topical antibiotics. So typically clindamycin is given. So topical antibiotics or topical clindamycin डाल दिया. Third stage में again add on TR plus TC. प्लस साथ में क्या करेंगे? नाउ वी वांट टू ऐड बेंजोइल पेरोक्साइड, राइट? सो बीपी, बेंजोइल पेरोक्साइड ऐड कर दिया हमने साथ में. एंड फाइनली नोडुलोसिस्टिक, व्हाट डू यू वांट टू गिव? यू वांट टू गिव आइसोट्रेटिनोइन. आइसोट्रेटिनोइन देने से पहले व्हाट आर द थिंग्स यू वांट टू डू? One, rule out. Do UPT and first rule out कि patient pregnant नहीं है. Second, do LFT because this is hepatotoxic. And if patient is planning pregnancy, how long you want to stop isotretinoin? Very important questions. Not 6 months, 1 month. 1 month stuck, you have to stop isotretinoin before planning pregnancy. You have to do LFT. What is the most common side effect of this? Dry eyes, dry lips. Yes, dry lips is the most common side effect. And what else? What is a specific side effect of this? Is dish. Remember dish, diffuse idiopathic skeletal hyperostosis. So there you will see ALL के along flowing ossification, mimic of Ang's pond. Okay, so ये dish है. What else? One of you also mentioned something which was true. Yes, pseudotumor cerebri. Pseudotumor cerebri is another side effect that you have. So these are all the points that you have about isotretinoin in a nutshell. Got it? So ये हमारा हो गया. Hypertriglyceridemia also. ठीक है, increased triglycerides. So this is all that you want to know. Dish is diffuse idiopathic skeletal hyperostosis. Yes, acitretin के लिए हम लेंगे 3 years actually. 3 years, yeah. कल बताऊंगी, ठीक है. एसिट्रेटिन 3 years, राइट? हाँ, इसके लिए 3 years तक प्रेगनेंसी अवॉइड करना है. दिस इज समथिंग जो हम सोरियासिस में देंगे, सिवियर सोरियासिस. ओके, हाँ, पस्ट्यूलर सिवियर सोरियासिस वी विल गिव. We are not finishing on 14th. We plan. I haven't planned the classes of 14, but definitely before 4th we can't finish. We have so many classes. How will I do in 3 days, right? But you can do rest of the modules, right? 3 modules. So maximum subjects we've done. Only 5 subjects are left, which you can do here and there. Dish is diffuse idiopathic skeletal hyperostosis, which is a ossification along ALL. ठीक है, फटाफट papillosquamous disorder करें. Most of it we've studied, right? So now guess from the histopathological findings. Good. This is psoriasis. So we are saying everything is there, right? Hyperkeratosis, parakeratosis. We already know all of this. Munro's microabscess in corneum. यहाँ पे क्या मिलेगा? Kojog's microabscesses in the spongious layer. Just put a tick tick, है ना? I know everything. Apart from that, what were we having in the granular layer? Tell me that. Agranulosis or hypergranulosis? Agranulosis, right? You can't have everything. So we are going to give agranulosis here. Then what is happening here to the rete ridges? Do you see how prominent they are? So these are called as clubbed shaped rete ridges, or C se hi yaad rakho, these are also called as camel foot. Camel foot rete ridges. And one more finding which I haven't told you is dilated blood vessels with surrounding inflammation. So you'll have these blood vessels and inflammation in the dermal papilla also. So these are all the findings of psoriasis. Do they seem very easy now? Yeah, कि ये तो हमको आता ही था. And yes, suprapapillary thinning also. So ये है. Okay. Right. Now, what are the images? So always one word only you have to think: extensor surface, erythematous lesions, and one word: silvery scales. The moment you hear silver scales, pruritic lesions, not papular lesions, silver scales, erythematous extensor, this is psoriasis. Most common, कहीं पे भी most common है, we use the term vulgaris. Psoriasis vulgaris. Does Kim Kardashian have psoriasis? What are you saying? Psoriasis vulgaris. Okay. Right. Palm मतलब extensors पे typical मिलेगा. Okay. And what do you see in the nail? Yes, as we have already done, it is going to be irregular. She does. Okay. Bad for her. Irregular pitting, and you will also have the typical oil drop sign, right? ये जो yellow yellow दिख रहा है, this is your oil drop. ठीक है. So this is about that, and yeah, you can have subungual hyperkeratosis. Typically ये है जो हमने देखा. Clinically, what if you scrape off the lesions, you will find these papillae, you will find this blood vessels, which was basically what you were seeing here, dilated blood vessels. This is called as the Auspitz sign. And what is this test called? This is the Grattage test. One more word that you want to remember here is something called as Warnoff's ring. और ऑयल ड्रॉप हर्ष आर दीज येलो येलो चेंजेस दैट यू सी, है ना? तो येलो येलो हो जाएंगे ऑयल ड्रॉप जैसा. Warnoff's ring, yeah, and you also see something called as Berkeley membrane here, right? So all of these are buzzwords for psoriasis. So these three stick together. Whenever you basically do a grattage, यहाँ पे Auspitz sign और Berkeley membrane मिलता है. And in lesion, sometimes you can have a hypopigmented halo. That halo is called as the Warnoff's ring. Okay. Correct. PGE2 के साथ relation है, which I didn't know. Okay, so this is about Warnoff's ring. What else was I about to tell you? Yeah, so this is about psoriasis. Now we have variants of psoriasis. Whenever you see a child and they'll give you the history that the child had URTI, following which he had crops of these erythematous lesions, what kind of a variant of psoriasis is this gonna be? Yeah, this is gonna be guttate psoriasis. Here the drug of choice changes. What is the drug of choice? Here you want to give antibiotics. And URTA ko theek karo. Give azithral, give macrolide. Okay, so that is what we are doing for guttate. Then what is this? When you see pustules here, this is your pustular psoriasis, isn't it? Now pustular psoriasis can become generalized. When pustular psoriasis is generalized, what is the name of that disease? One, Zumback disease. But when pustular psoriasis is generalized in a pregnant female, like in this case, she is pregnant and she has generalized pustular psoriasis, what is that called? That is called as impetigo herpetiformis, right? So misnomer, it is not related to herpes at all. God, my handwriting took a hit here. Impetigo herpetiformis. Okay, so this is not related to herpes. This is a misnomer. Okay, so this is what you see about pustular psoriasis. No, this is not the one which occurs, Neha, after stopping steroids. There is pustular psoriasis which can occur after a sudden withdrawal of steroids, right? So remember, this can occur if you stop steroids suddenly. And one more thing, in pregnancy, Can we give methotrexate? Can we give cyclosporin? Not really, right? So here the drug of choice is gonna be steroids. So here the drug of choice is also steroids. So two things about steroids. एक तो छोड़ने पे भी आ रहा है, and drug of choice is also steroids. If steroids is not in your option, then what is the second best drug that you can give, which was asked as a previous year question? Cyclosporin. Good. So the second best option is cyclosporin if steroids are not there. Very nice. So this is about pustular. And finally, complete body, the most severe type where we were giving acitretin. This is erythroderma, right? So this is erythrodermic psoriasis, wherein complete body is involved. And here the drug of choice, first line is going to be methotrexate. Only when methotrexate doesn't respond, uske baad hum karenge acitretin. So that is your second line. Okay. So this is about all the questions which can be asked here. Topical steroids तो effective ही नहीं होगा. That's why we can give systemic also pregnancy में ऐसा कुछ नहीं है. Right, so this is about pustular psoriasis. One this thing sign, very important, last year ka question. This is isomorphic phenomenon, also called as Koebner's phenomenon, which means that anytime you have trauma, the lesion will increase, है ना? Increases with trauma. So what is that? Again, von Zumback also, anytime you are severe, no, drug of choice will be methotrexate, first line. So three things which can show you isomorphic or Koebner's phenomenon. One, we are studying only psoriasis. Something which always stays with psoriasis is lichen planus. And the third thing is what we study tomorrow, pigment disorder, which is vitiligo. है ना? तो ये तीन है. इसी के अलावा there is something called as pseudo-Koebnerization phenomenon. What is pseudo-Koebner's? Wherein it's actually inoculation. So viral warts or molluscum contagiosum is actually getting inoculated. It's not because of trauma. वो आप वैसे ही उसको spread करा रहे हो. So this is pseudo-Koebnerization. What is reverse Koebnerization phenomenon? When it heals. Wherever you do trauma, it will heal. That is also seen with psoriasis. Okay, so these are all your questions regarding Koebnerization. Next disease, very very quickly, बहुत सारा कुछ पढ़ना है हमें. What abhi to, I think leprosy I will have to give you as homework. What is this? Yeah, this is lichen planus. So this is lichen planus. What are all the P's that you know for lichen planus? One, purple, then papular, then polygonal, flat topped, जिसको हमने P बना दिया, plain topped, right? Pruritic. So all of these P's are gonna be seen here. And what are these white things, guys, that you are seeing? These are your Wickham's stria. And Wickham's stria are because of what pathological basis which we already know? Yes, very nice. This is because of hypergranulosis, right? So this is about lichen planus. Association with which virus, guys? Very, very important question. HCV, right? So remember Hep C, cryoglobulinemia, lichen planus are all associations of Hep C. Hep B के साथ which vasculitis you will always remember? PAN, right? Hep B lesser than Hep C, right? Hep C is typical. PAN is your polyarthritis nodosa, Hep B. ये क्या है? Hypertrophic, right? So can you see how it's raised? So this is hypertrophic variant of lichen planus. On the other hand, anytime something is sun exposed, when lichen planus ka variant is in a sun exposed area, what is the word we refer to? Actinic. So this is actinic lichen planus. Okay. And what are the typical nail changes that you will see here? This is a pterygium, dorsal pterygium that you will see, and you can also see tenting, which is called as the pup tent sign. So you will see tenting, you will see pterygium, which are the typical signs of lichen planus. Okay, yeah, onycholysis also. Then when we, just a second, guys. When we go to the oral findings, right? जब हम mucosa, oral mucosa की बात करेंगे, तो can we do it in a differential diagnosis pattern based approach? Anytime oral white lesions are mentioned, think of three things. First, ask yourself, can I wipe it off with a membrane? If you have white lesions which are wipeable, which can be wiped off, what will you consider? You'll consider candida. On the other hand, wipeable नहीं है, ठीक है, first step. Then you look at two things, or just see, do you have these white lacy reticular pattern? Then what is the diagnosis? If you have lacy reticular pattern, it is lichen planus. If you don't have lacy reticular pattern, what is the diagnosis? Oral hairy leukoplakia. Very nice. Oral hairy leukoplakia associated with which virus, guys? Epstein-Barr virus, right? So see how virus is coming everywhere. यहाँ पे HCV आ गया, यहाँ पे EBV आ गया. Okay, yeah, this is Wickham's. Can you see this is Wickham's? So diagnosis here is lichen planus. के मुंह पे लिखेंगे lichen planus. Okay, so this is about this. So they can give it this as pattern-based approach. So clinical scenario देंगे कि you have white lesion which could be wiped off, which couldn't be wiped off, and that is what it is. Okay, चलो ये सब आता है फटाफट. Orthokeratosis क्या था बताओ फटाफट. When you were hyper but you were not para, so which means that thickened corneal layer but nucleus नहीं है ना. तो यहाँ पे दिख भी रहा है कि बहुत सारा है but nucleus retention नहीं है. So ortho hypergranulosis, because of which we had Wickham's triad. Then do you remember DLE, BLE, basal cell degeneration? Yeah, so basal cell degeneration is DLE also. So इसमें you are seeing this Max Joseph space because cells have degenerated, they have formed this civet or colloid bodies, and you will also have this inflammation, lichenoid band of inflammation. No, no, not same, no. Hyper minus para is ortho. Means you have hyperkeratosis but not parakeratosis. That is ortho. ठीक है. तो काइंड ऑफ पैरा ओनली या बट उन्होंने बोला कि नहीं ऐसे कैसे. वी विल इंट्रोड्यूस वन मोर टर्म इन यू नो नीट पीजी एंड वी विल मेक पीपल्स लाइफ डिफिकल्ट. सो उन्होंने बोला कि ठीक है तुम अगर हाइपर नहीं बट पैरा हो देन यू keep one more ortho. They could have just said ki para, right? But no, we will introduce one more. So that's orthokeratosis. Okay, right. Then next one, very typical. ये वाले गलत नहीं करना, ठीक है बिल्कुल. ये क्या है? Yes, this is pityriasis rosea. So this is pityriasis rosea, which is your again a papillosquamous disorder, wherein it will start off usually in the trunk as one lesion, which is called as the herald patch. तो ये हो गया starting herald patch, which has what kind of scales? This is very very important. This will have this collarate of scales, है ना. तो इसको बोलते हैं collarate of scales, and these are hanging, you know. So collarate of scales भी बोलते हैं और इसको cigarette paper scales भी बोलते हैं. So collarate of scales, cigarette paper, and because they are hanging, it is also called as hanging. देखो एक ही scale का कितने नाम. Hanging curtain sign. So collarate, cigarette paper, curtain. Good thing is हर जगह पे C आ गया, ठीक है. So this is your P rosea, ठीक है. तो उसके साथ साथ you will basically have all of these lesions which appear like a what pattern. You can see one Christmas tree forming here, right? So this is your Christmas tree, fir tree pattern which forms here. Association with which virus? Yes, HHV 6, 7 दोनों अलग अलग जगह दिया. You will remember HHV 7 more common than 6. ठीक है. So बस इसके अलावा और कुछ. What happens to palms and soles? Are they involved? Not involved. Spared. Palms and soles are spared. यहाँ पे स याद किया था तो ये भी स से याद रखो, spared. Okay, so this is about that. Then P rosea किया तो एक और P कर लो. This came in one of the questions. P rubra pilaris. Rubra means there is reddening. Pilaris means because it is associated with hair follicles, right? So this is pityriasis rubra pilaris, and you will have islands of skin which are spared. The buzzword is islands of skin which is spared here. This also kind of looks like phrynoderma from vitamin A deficiency, right? Like a nitidus नहीं, like a nitidus जैसा नहीं है, because this is along hair follicles. Like a nit, so history में देंगे कुछ ना कुछ vitamin A related, right? So otherwise you can't distinguish. ठीक है. P rosea is HHV 7, 8, no 7, 6, 6 and 7. How does lichen nitidus appear? See this. Is this a long hair follicle? No. इसमें से कीड़े से lesion. This looks like lichen nitidus, right? So nitidus जैसे lesion होंगे, which are not a long hair follicle. That is the difference. Understood? Will you make this mistake? No. So this is lichen nitidus. So this can be seen anywhere in the body, right? And histopath में you will have this very typical feature. ऐसा लग रहा है ना कि कोई ball पकड़ रहा है. So this is also called as claw clutching ball. Why does it occur? Why does anything occur? I mean, these are diseases, no? So there is no cause here. It's just a disease which happens. Okay, so this is what do I say? Pityriasis rubra pilaris. Okay, so this is claw clutching ball. Why did my conjunctivitis happen today? I don't know. Right, so sometimes you don't know. So this is claw clutching ball which happens. यहाँ पे inflammation ऐसे आ जाएगा. All right, so this is lichen nitidus. Then what is this? Where you have white lesions, you will have black lesions, multiple color, versicolor. This is pityriasis versicolor. Is it Is it actually a papillosquamous disorder? It is, but it is an infective papillosquamous disorder, right? So this is actually a fungal infection. So here I can tell you why does it happen. This is a fungal infection because of Malassezia furfur. है ना? So this is Malassezia furfur, where you will have hypo also, hyper also. Hypopigmented lesions क्यों है यहाँ पे? Because this fungus no produces azelaic acid. Azelaic acid you must have also seen, you know, a lot of females take it for whitening, है ना, fair and lovely types. So because this is going to inhibit tyrosinase. So tyrosinase inhibitor है, इसलिए सफेद सफेद हो जाएंगे. But hyperpigmented lesion, hyperpigmented क्या है? कितने स्लाइड्स बाकी है? थक गए क्या? अभी तो बहुत बाकी है, अभी तो आधे हुए हैं. This is because the melanosomes increase in number or size. जब भी कोई ऐसा पूछे तो बोलो size, है ना? So this is going to increase in size, not in number. Okay, remember that. So here hyperpigmented. बाकी ये तो पता ही है. When you do a KOH mount for this fungus, you'll see this spaghetti and meatball. ये तो सबसे cliched सवाल जो सदियों से आ रहा है. Spaghetti and meatball appearance on KOH mount, and can you grow it on SD agar? Yes, grow it on agar, but because this is lipophilic, we will also add olive oil. And yes, they will give you this fried egg colony. Do you want me to go into what all things show fried egg? Everybody knows, no? Mycoplasma and HCl, bus. Anything else you know? And oligodendroglioma also. I went into it. So 4 things go show you fried egg. Anything else that you know? Bas na? ठीक है. Then we go into infections. Seminoma also? Cool. I don't know. Seminoma, this germinoma, whatever. Okay, so now we go into infections, right? Bacterial infections is what we are going to be starting off with. Okay, so far so good, guys. Anything else? Right, Mansi has written everything for us. Very good. Chalo. So infections. Whenever you see honey crusting, बच्चों में ऐसा honey crusting word आ जाए, do not make such mistakes. This is impetigo. Impetigo contagiosum. Strep or staph or both? ब्रेक नहीं यार, ब्रेक कहाँ, 15 मिनट में तो क्लास ओवर है. स्ट्रेप एंड स्टैफ बोथ. बट व्हेन यू सी दैट यहाँ पे बुल्ले बन गए, व्हाट इज दिस? दिस इज बुल्लस इम्पेटिगो. कॉज स्ट्रेप और स्टैफ और बोथ? Only staph. Why only staph? Because staph is the only one which produces this exfoliative toxin. This exfoliative toxin is going to act on desmoglein 3. Remember desmoglein? कल पढ़ेंगे. Desmoglein 3 पे act करता है. Then when you have this red raised lesion, when you have this raised lesion, well demarcated, very very important. This is erysipelas. So remember the point, where does it go till? So abhi tak these are both epidermal. This will go into superficial dermis, papillary dermis tak jayega. So this is erysipelas. That is why it is well demarcated. Strep or staph or both, but remember typical is strep here. Strep में more common है, ठीक है? Both, but strep is more common. And when it is ill defined, where there is no line of demarcation going till the entire dermis, this is what? This is cellulitis. Okay, this is cellulitis. Derma for first aid for derma. No, don't do first aid for derma. It's not enough, it's not good. Derma only for first second, prof. I'll tell you when to do first aid. ठीक है? So 4 disease हो गई. What is million year sign? So whenever you see pinna getting involved, right, this is a $1 million sign कि एक ही diagnosis हो सकता है. E for ear, E for erysipelas. Because ear में ना you only have superficial dermis. That is why when ear is involved, it is erysipelas only. ठीक है? तो ये $1 million year sign हो गया. अब follicular based, whenever you have hair follicle के along this, you must have seen no beard के साथ साथ, this is folliculitis. But when you have an abscess along one hair follicle, abscess बन गया. What is this? फॉग को ही कंटिन्यू करते हुए, दिस इज फ्यूरंकल. Yeah, so this is furuncle. Yeah, these are more common with staph. वैसे दोनों में हो सकता है, staph is more common. Furuncle. And when you have multiple pustules, nape of the neck is very common. And the history will be what? इसमें आपको दिए होंगे diabetes, right? So the mnemonic is uncle. So carbuncle, remember a diabetic uncle जिनकी neck पे ऐसा abscess है, ठीक है? तो diabetic uncle को याद करो, carbuncle. Okay, so this is your hair follicle based. तो फटाफट करते हैं. If only epidermis, impetigo. Hair के along, folliculitis. No, not tinea. Can't distinguish really, but tinea barbae typically will have all your tinea wale features where there's central, scales and all. ठीक है? So this is folliculitis. Furuncle, carbuncle, you will have abscess associated. One है तो furuncle, multiple है तो carbuncle. Erysipelas is superficial dermis, cellulitis is deep dermis when all the layers are involved, necrotizing fasciitis. So, three more lesions. When you have ecthema, ecthema dekha tha, superficial tak. Ecthema gangrenosum. Do not mix up these terms. So here you will be given the history that there is a neutropenic patients with such very khatarnak looking lesions. So this is gangrene jaisa. This is called ecthema gangrenosum. So this is because of pseudomonas. And just to correlate pseudomonas ke साथ दो other infections you want to remember. If they give you the buzzword hot tub में नहाने से folliculitis, you were taking a bath in a public hot tub and you got folliculitis, jacuzzi syndrome, again pseudomonas. When you got hit by a nail, नेल के साथ साथ जब इन्फेक्शन हुआ, राइट, तो चल रहे थे पैर में नेल लग गया, राइट, दैट इज ऑल्सो पॉजिटिव ऑर्गेनिज्म, सूडोमोनास. ठीक है. देन वन मोर ecthema. When you have this typical image, very very important, orf virus. What is this ecthema called? It's going to be contagiosum, right? Ecthema contagiosum. So this is because of a parapox virus, which is your orf virus, which is a zoonosis, right? Animal handlers mein hoga. One more thing in animal handlers where you see this black eschar. So just so that you correlate, I've kept this together. Wool sorters disease, which is cutaneous anthrax, right? So this is again, both of these are zoonosis. Look out for black eschar in the finger, otherwise as a pustule. This is ecthema contagiosum. Do not mix gangrenosum with contagiosum. ठीक है. Three very linear looking lesions. This was asked in the latest exam, same image which I had taken in Mer came. What is this? Yeah, so when you have this primary infection, then in the subcutaneous plane you have linear. Do not say sporotrichosis. Very very important. That is why मैंने तीनों साथ में लगाए हैं. When you see linear subcutaneous lesions, this is lymphangitis. Okay, so this is just your step or staff which is going along the lymph, and this is lymphangitis. Very important. ट्रीट कैसे करोगे? प्राइमरी स्टैफ और स्टेप को ट्रीट करो, गिव ऑगमेंटिन, है ना, अमोक्सक्लाव दे दो, ऑगमेंटिन दे दो, lymphangitis will also get treated. Second, when you see this cutaneous nodulo ulcerative lesion, and history क्या दिया होगा? Gardner, Rose Gardner's disease. This is sporotrichosis. Let's quickly discuss sporotrichosis. So also called as Rose Gardner's disease. ऐसे lesions मिलेंगे. Histopath में what do you see? You will see these asteroid bodies, right? So these are asteroid bodies. Asteroid bodies all कौन से disease में मिलते हैं? Sarcoidosis. Good. So asteroid bodies are because of this immune complex phenomenon. Just remember the name. This is your antigen antibody reaction, which is called Splender-Hopley phenomenon, right? And what else do you see here? This is also looking like a rosette, right? So this is also looking like a rosette of conidia. No, this is not brush broom. Brush broom is seen in Taleromyces, right? Marnefi, Penicillium marnefi. That is brush broom. So this is your rosette of conidia that you are seeing here. So all of these are your mycology features of sporotrichosis in one place. So will you remember this image? Exam में यही image आएगा. So skin पे nodular ulcerative है Rose Gardner. अगर subcutaneous है lymphangitis. One more. Foot पे when you see, ऐसे बोलेंगे बीच पे घूम रहा था, ऐसा ऐसा ऐसा. As a lesion, what do you call that? This is cutaneous larva migrans, right? So this is cutaneous larva migrans. They're very, as a snake-like serpiginous lesion. Serpiginous was the word I was looking for. The serpiginous lesion, serpiginous, like cutaneous larva migrans. Okay, so ये किससे होगा? This will be seen with any parasite, है ना? Ankylostoma, hookworm is ankylostoma, cutaneous larva migrans. And again, very very important, ये हर alternate exam में आ रहा है. Foot में, when you see warty lesions. What is this? This is chromoblastomycosis. Why chromoblastomycosis? Because you see these copper penny bodies, है ना, chromo, copper penny body. So do not confuse all of these. Very very important. जो अभी पढ़ा रही हूँ ना, ये pattern based approach से question आएंगे. Medular bodies भी बोलते हैं इनको, बहुत सारे नाम से बोलते हैं, स्क्लेरोटिक बॉडीज भी बोलते हैं, बट मोस्ट कॉमनली आस्क्ड इज कॉपर पेनी और मेडुलर. इमेज बेस्ड क्वेश्चन आएगा, 1000 बार पूछा हुआ. कॉजेटिव ऑर्गेनिज्म फॉन्सेशिया और फाइलोफोरा. ठीक है. एंड व्हाट इज दिस व्हेन यू हैव ब्लैक? सो दिस इज कॉल्ड एज टीनिया nigra, black for nigra. So whenever you see blackish lesion, they will ask you black fungus, है ना, सब लोग म्यूकर को ब्लैक फंगस ऐसे फेमस कर दिया, विच इज रॉन्ग. द एक्चुअल ब्लैक फंगस इज व्हाट? इट इज एक्सियोफिलिया वर्निकी बिकॉज इट कॉजेज टीनिया नाइग्रा. ठीक है, याद रखोगे एवरीबडी. सो दिस इज अबाउट दैट. अब इन्फेक्शन और दहशत मचा रहे, दे आर गोइंग डीपर. व्हेन यू हैव गैस, कैन यू सी सीटी गाइस, रेडियोलॉजी, रिमेंबर ब्लैक ब्लैक एयर होता है एक्सरे में, सीटी पे. सो व्हेनेवर यू सी ब्लैक ब्लैक एयर एंड यू सी कंप्लीट खतरनाक इन्फेक्शन, दिस इज गैस gangrene. Anaerobic infection है obviously, so most common Clostridium perfringens, right? And if you have all the layers which are involved, very very khatarnak infection, necrotizing fasciitis. Multiple times asked question, जब groin area का necrotizing fasciitis हो जाए, we call it Fournier's gangrene. One more gangrene of the surgical site, when surgical site is open and you have this yellow burrowing gangrene, this is called as Melanese gangrene. Melanese gangrene is also called as burrowing gangrene. You'll see it's burrowing, all right? So these are all the gangrenes that you need to know as image-based spotters. Necrotizing fasciitis. NF is necrotizing fasciitis. See this again. Do you remember axilla पे अपन ने क्या देखा था? When you see those spots in the axilla, what was that? Fox-Fordyce disease. Remember, एक्राइन ग्लैंड या एपोक्राइन ग्लैंड का प्रॉब्लम, विच ग्लैंड का प्रॉब्लम? दैट वाज एपोक्राइन, है ना, एक्सिला एपोक्राइन, राइट. What else? When you see blackish lesions, acanthosis nigricans, and when you see red lesions, what is this? This is erythrasma. If you see whitish lesions, it would be not whitish but red ke upar white, it could be candida also, right? So this is erythrasma. Here one very important thing, when you do Woods lamp examination, you will see coral red color, right, on Woods lamp. So that is there. And what else? Causative organism kya hai? Corynebacterium mini mitusum, right? So remember mini Corynebacterium. That is your erythrasma. What else do you want to remember about this? Yeah. So why this mini mitusum does this is because it has keratolytic enzymes. All right. So this has keratolytic enzymes, and yeah, this also produces coproporphyrins, because of which it shows you this coral red color. And one more manifestation because of this keratolytic enzyme is this will cause pitted keratolysis. This will cause this pitted keratolysis, same bacteria. Okay. Yeah. So this is about this. One more infection, when you see such manifestations, I'll give you a history. So this is basically a Retter's syndrome, not syphilis. This is Retter's syndrome, which is actually because of maybe diarrhea or an STD. So they'll give you history ki ya to GI ya STD infection tha, and after that the person had a triad. Triad of what? Can't see, can't pee, can't climb a tree. Can't see matlab, even though can't see, conjunctivitis you can see, right? वो misnomer है, but still can't see, conjunctivitis. Can't, and see on what day we are doing this, on the day I have conjunctivitis, right? So you can never forget this, the conjunctivitis. Then you can't pee, so urethritis. Conjunctivitis, urethritis. Can't climb a tree, arthritis. So you'll have arthritis, urethritis, conjunctivitis, and two cutaneous manifestations. This cutaneous manifestation को क्या बोलोगे? This is called as keratoderma blenoragicum. लिखने में इतना टाइम लगेगा. Keratoderma blenoragicum, right? So these are the skin lesions, and in the penile area, when you see this cercinate lesion, this is called as cercinate balanitis. Yeah, I told no, this is what is seen in foot. So ये वाले इसके lesser known cutaneous manifestations है, right? So this is what is Retter's syndrome. ये क्यों होता है? Because of GI and STD infection, you know, you will have this autoimmune inflammatory arthritis. ठीक है. Can't hear a buzzing भी क्या था? बताओ जरा. When you have eye, hear, and yeah, that was Alport syndrome, right? So when you have kidney, you have SNHL, and you have ear, and you have eye keratitis, that is Alports. इसलिए ये सारे useless है, because आपको वो याद रह गया buzzing भी, but you forgot primary क्या था, right? So you have lenticonus, you have SNHL, and you have renal involvement. So that was Alports. Alports is which collagen? Collagen 4. What chain of collagen 4? Alpha 3, alpha 4, alpha 5? Alpha 5. 5 is most common. कोई भी हो सकता है. Alpha 5 is most common. Remember, alpha 3 was good pasture. Alpha 4 is thin basement membrane disease, and alpha 5 is Alports. So remember, collagen ka 3 is good pasture, 4 is thin basement membrane disease, which are familial hematuria, benign familial hematuria. Alpha 5 is Alports, and here what do you see in the basement membrane? Going to be seeing a basket weave pattern. Okay, sorry, basket weave pattern. And what is the inheritance? Ab kari lo. X-linked, dominant is most common, but it can have any sort of inheritance. Okay, recessive, autosomal, सब कुछ हो सकता है. ठीक है, तो ये भी रिवाइज हो गया. Last thing, very rare, INICT specific, you can ignore also. If they give you Hep B, they give you COVID-19, Epstein Barr, उसके बाद ऐसा skin lesions मिल रहे, papillosquamous, and they are giving lymph nodes, the rare syndrome called Gionati Crosty. तो ये पूछेंगे तो एम्स में पूछेंगे, अभी तक पूछा नहीं. And if they ask, I will take 100% credit for this. I will take 100% credit for everything that you achieve in life, but this I will definitely take. Okay, so this is Gionati Crosty syndrome. Yeah, IgG4 also. Okay, so now the time is up. So now can you, your homework for the day? Definitely I can't do leprosy because it's the most important thing. So that's the only thing that you have to do. What is the midnight express? बताओ, कौन बताएगा मुझे कि leprosy का midnight express कौन सा है? Very good. Midnight Express 29. So your homework is, everything else I will cover in Derma. You don't have to do anything. You just have to see this one Midnight Express. You finish off leprosy. बाकी सब कुछ मैं करा दूंगी. ठीक है? So rest of it is tomorrow. Apart from this, what else you have to see? STDs. Correct. STDs का more भी देखना है, but can I take 5 more minutes and I will just teach you STD. एक ही slide में मैंने सब summarize कर दिया genital ulcers को, तो वो मैं बता देती हूँ, but everything else you will do. ठीक है? बाकी previous year question हम कल अभी कर ही ले. Previous year question from whatever we have studied today कर ही लेते हैं ना, कहाँ कल करेंगे, कर ही लेते हैं. चलो 5-10 minutes रुक जाओ और. So genital ulcers can be painful or painless. So this is the approach to, but so your homework is only leprosy, everything else we are doing. ठीक है? So genital ulcers can be painful or painless. Painful है तो दो चीजें. If you see such, I will tell you the buzzword and you will make the diagnosis. Polycyclic erosions है, vesicle है, तो remember this is not chancroid, this is HSV. So the buzzword is polycyclic erosions or vesicles, erythematous. कल बताऊंगी नेहा, नहीं कल नहीं बताऊंगी. When you see leprosy murno, you will get your answer. ठीक है? So this is herpes simplex virus. When you see वैसा ऐसा bleeding, painful ulcers, you cry, right? So Haemophilus ducreyi. So this is chancroid. So this is H. ducreyi. अब पेनलेस में तीन चीजें हैं. पेनलेस में इफ यू सी कि ऐसा बहुत ही इंड्यूरेटेड सा अल्सर है, वेरी पेनलेस, बटन लाइक अल्सर है, हार्ड अल्सर है. इवन इफ यू सी द लिम्फ नोड्स, दे आर पेनलेस, शॉर्टी लिम्फ नोड्स बोलते हैं, ऐसे फील करने में छोटे छोटे पेनलेस लिम्फ नोड्स है. डायग्नोसिस इज syphilis. When you see beefy is the word, lot of granulation tissue. What is this? This is Calymattobacter, what? Donovanosis, right? So this is donovanosis. So Klebsiella or Calymattobacter donovanosis, right? So this is what that is. And when you see कि ulcer जो था वो तो transient ulcer था, but now you have a painful bubo, you have a painful lymph node which can suppurate. This is what? This is lymphogranuloma venereum, and you are seeing कि inguinal ligaments से separate होके this is forming a groove sign, right? So this is groove sign. All right, so this is about genital ulcers. Very quick approach. बस ये slide देख लो. ठीक है? So apart from this, if you haven't seen MKT of STD, one more homework that you have is do MKT of STD. ठीक है? तो उसमें आपको सब मिल जाएगा. You will get STD kits, you will have vaginitis, you will have everything, right? तो उसमें kits भी cover हो जाएंगे. MKT 3 और 4 I think वो सारे links उसमें है. ठीक है? I'll post the link. अभी क्या करूंगी, क्लास के बाद कोई डाल दो ना ग्रुप में, दोनों का लिंक्स डाल दो, मिडनाइट एक्सप्रेस एंड एमकेटी. सो वी हैव एवरीथिंग इन वन प्लेस. फाइन. वेरी क्विकली 2-3 more things we want to do. बताओ. अब टीबी कर लेते हैं, क्यूटेनियस टीबी. वेरी क्विकली, व्हाट इज द मोस्ट कॉमन टाइप ऑफ क्यूटेनियस टीबी? Extending the class by 5 minutes. Okay. Yeah, so this is lupus vulgaris, most common. So lupus vulgaris. Okay, so what will you see? You will see that there are these lesions which have central what? Yes. So these are ulcers which have central scarring, isn't it? So there is central scarring that you're going to be seeing here in erythematous plaques. When you apply a slide on it, this is called as diascopy test. And diascopy test, you will see that in the periphery, there are these so many times asked apple jelly golden brown nodules, है ना? So this is so cliched. Apple jelly golden brown nodules seen in lupus vulgaris. बता रही हूँ, central अभी बता रही हूँ. So this is erythematous with scarring. Got it? Then, so this is your most common type of TB, which happens via what route? This is your hematogenous spread, right? So you had pulmonary TB, and when it goes to the skin, this is your hematogenous TB. बता रही हूँ ऋषिकेश, I'll tell you. So this is hematogenous. Then what is this? When you have underlying lymph nodes and then you have this sinus and bone involvement, this is called as scrofuloderma. So lupus vulgaris is the most common type of TB in adults. If they ask you in children, what is the most common type of TB? It is scrofuloderma, so, है ना, so and child. And what is this? When you see chota lesion, this is lichen scrofulosum, right? So scrofuloderma se hi kar lo, scrofulosum, whatever. Okay, so that is your this thing. So the question was, is which of the following is not a variant of lichen planus? Then they had given all of these names, four bada names, out of which one of them was this, जिसमें जिसके नाम में आ रहा है scrofulo. Okay, so remember, this is a hypersensitivity reaction to TB. Okay, this is not primary TB. Will you remember this, guys? So this is hypersensitive. One more hypersensitivity reaction to TB जो हमने बहुत पहले पढ़ा in today's class only. What was that? Which had lobular paniculitis. Very nice. Erythema induratum of Bazin. तो दो hypersensitivity reactions हमारे हो गए, which was lobular paniculitis. ठीक है, तो ये भी हो गया. अब दो और सेंट्रल करने थे. So when you see कि सेंट्रल में क्लियरिंग है and you have scales, what is this? This is your prototype tinea, है ना? तो tinea corporis, tinea cruris, wherever you have tinea, this is your tinea. And when you see कि central crusting है, crust formation हो रहा है, what is this? This is leishmania. No, it is not a variant, Varsha. That is what I said. This is a hypersensitivity of TB, right? This is not a variant of lichen planus. खाली नाम रख दिया क्योंकि ऐसा छोटा छोटा था इसलिए. Nitidus जैसा लग रहा है ना देखने में, but it is not. They'll give you history of exposure to tuberculosis. ठीक है, so this is our tuberculide. So these are all tuberculides. Yeah, I will increase competition. No, why are you looking at it that way? अपने को क्या करना है? अगर इस क्लास में सारे बच्चों का रैंक आ गया, इसका मतलब ये है कि आपका रैंक नहीं आएगा. No, right? अगर सबका ही रैंक आ गया तो क्या जा रहा है? Everybody has a seat. You know, there are enough seats for everybody to get. So, I mean, it's not like one person will get selected तो बाकियों का नहीं हो रहा. सारी हो जाओ, बढ़िया ना? So there's tinea and then there is leishmania. You only need one, exactly. है ना? So ये central crusting है. So ये पूरा concept ही ना गलत है actually. Anyways, छोड़ो ये सब ज्ञान बाद में. So central scarring, this is central clearing, this is central crusting. Two very good concept बोल रही हूँ. Two very important infections. When you see polycyclic, बच्चों में स्कूल में हो गया, फिर सबको ही हो रहा है. What is this? Chickenpox, right? Varicella. So this is chickenpox where you have polycyclic erosions, कुछ scar कर रहे हैं, कुछ crust कर रहे हैं. And when it recurs, what is this? A longer dermatomal distribution. So many times this images come for no reason, so easy. This is shingles, right? So shingles, what is the most common complication here? It is post-herpetic neuralgia. Can you tell me the definition of post-herpetic neuralgia? Beyond how many weeks if there is pain? Repeat Ames question. Beyond 4 weeks. Very good. And what is this viral? So both of these are what viruses, guys? Varicella zoster, right? I'm sure you know that. What is this? So many times this question has also come. Do not get this wrong. Molluscum contagiosum. Molluscum contagiosum will have these pearly white umbilicated dome shaped lesion. ये वाले words ना ऐसे जहन में डाल लो. Dome shaped umbilicated pearly white. They will use these words always, and your diagnosis is pearly. Is your diagnosis molluscum contagiosum caused by pox virus, which is the largest virus with complex symmetry. And what are these bodies? HP bodies, Henderson Peterson bodies. ठीक है, which are your intracytoplasmic exclusions. फटाफट से previous year questions करेंगे सारे ही. Okay, so इससे पहले या चलो पहले ये करो. Which of these layers has abundance of desmosomes? So basal, corneum, basal, spinosum, granulosum, or corneum? C, right? So here spinosum has the desmosome. So correct answer is C. Identify the condition. Easy, no? आइसोमॉर्फिक फिनोमेनन। तो इसको फटाफट से जल्दी जल्दी में वॉर्न ऑफ साइन नहीं मार देना बिकॉज ऑफ सोरियासिस, राइट? सो दिस इज कॉबनर्स और आइसोमॉर्फिक। ट्रीटमेंट ऑफ चॉइस फॉर एरिथ्रोडर्मिक सोरियासिस वेरी सिवियर, राइट? सो सिस्टमिक स्टीरॉइड्स, स्टीरॉइड्स फॉर वेरी सिवियर सिस्टमिक स्टीरॉइड्स, मैंने बताया था ना। हाँ, मेथोट्रेक्सेट से भी बेटर है स्टीरॉइड्स, राइट? स्टीरॉइड्स इज द आंसर, नॉट मेथोट्रेक्सेट. Is it methotrexate? No, it's steroids, which is more than methotrexate. I think I had missaid in the thing. So steroids is the correct answer. Methotrexate will not be effective here. 5 second poll में कुछ नहीं होगा, इससे अच्छा वैसे ही कर लेते हैं, ठीक है? So remember steroids, ठीक है? What is the best treatment for this condition? First of all, what is this condition where you have this central sort of scarring? Central scarring. So diagnosis is lupus vulgaris. Okay, so this is ATT. So this is lupus vulgaris, erythematous plaques with central scarring. So ये थोड़ा सा मुश्किल सवाल था लास्ट ईयर के नीट का. So just remember this. What is this? जब एकदम ही फ्लैशी लीजन हो जाए, दिस इज एक्चुअली डिस्कॉइड लूपस एरिथोमेटोसिस. रिमेंबर कि एकदम ही क्लियर ये हमने शुरू में देखा था. सो द थिंग विद डर्मा इज आपको एक बार रिवाइज करनी पड़ेगी सारी इमेजेस, देन यू विल रिमेंबर, है ना? वरना सेम नीना खन्ना इमेजेस फॉर INICT फॉर श्योर. बट मैंने इंक्लूड कर ली इसमें, जो भी थे उस पीडीएफ में आई हैव इंक्लूडेड हियर. 5 मिनट में, 5 मिनट्स. व्हाट इज दिस? यहाँ पे लिम्फेंजाइटिस है, राइट? सो दिस इज लिम्फेंजाइटिस व्हिच इज अमॉक्सी क्लैव, ठीक है? राइट, यू कैन सी ऑल ऑफ द क्वेश्चंस इन डिटेल, फिर आराम से भी अटेम्प्ट कर सकते हो. इंटेंसली इची, सेंट्रल क्लियरिंग, सेंट्रल स्केल्स, दिस इज टीनिया. अंडरस्टैंडिंग है ना? समझ में आ रहा है ना सबको? ओके. ये लेप्रोसी हमने किया नहीं, बट लेट्स जस्ट डू कि पर्सन इज ऑन एमडीटी एंड नाउ हैज इन्फ्लेमेशन एंड एडिमा ओवर प्री एग्जिस्टिंग लीजन एंड नर्व इन्वॉल्वमेंट. सो जब प्री एग्जिस्टिंग लीजन पे हो, व्हाट टाइप ऑफ लेप्रा रिएक्शन इज दिस? लेप्रा रिएक्शन 1 or 2? This is lepra reaction type 1, right? So this is your type 1 reaction, and remember type 1 reaction is what kind of hypersensitivity? Type 4. टोटल ना 5 बनना चाहिए. So type 2 में there is type 3 hypersensitivity. So type 2 reaction is erythema nodosum leprae. That has type 3 hypersensitivity, whereas here it's 4. क्योंकि total 5 बनना चाहिए. So here the treatment is always continue and add steroids. Steroids are the drug of choice for both type 1 and type 2 reaction. ठीक है? Okay. Patient of psoriasis responded well to steroids, and withdrawal of steroids, pustular psoriasis happened. तो ये क्या है? आंसर में दे दिया, pustular psoriasis. ठीक है. Which of these is a true association? ये मैंने बताया नहीं है, but it is psoriasis and metabolic syndrome. इन दोनों का नाता है कुछ कुछ. Okay. बाकी there is a list also, drugs which aggravate psoriasis. उसमें याद रखना lithium और ACE inhibitors आता है, ठीक है? बीटा ब्लॉकर्स भी आए. somehow remember this from my preparation days. तो ये 3 चीजें हैं which are related, which aggravate psoriasis. Do you guys know this? होता है ना ऐसा? ठीक है. A lady presents with history of burning sensation on eating spicy food. बक्कल म्यूकोजा पे streaks है. No history of tobacco abuse but amalgamated third molar. What is this? So ये सब तो बेकार ही है. स्पाइसी फूड एंड ऑल. रिमेंबर दिस बायलेटरल व्हाइट लेसी स्ट्रिक्स, इट इज लाइकन प्लेनस, है ना? तो काम की बात तो यही थी. बाकी इसको देख के तो रोजेशिया याद आ जाता, बट इट्स नॉट दैट. ओके, सो इट इज लाइकन प्लेनस. ओके. 35-year-old male comes with complaint of baldness. On examination, well-defined bald patches are seen with no scarring. I'm also reading these questions for the first time right now only. Small broken hairs were seen in the surrounding area. What is this? एलोपेशिया एरियाटा, करेक्ट. एरिथीमा मल्टीफॉर्म में HSV, वेरी इजी. ठीक है. फिर क्या है? 12 अरे टाइम इज अप, वेट. ग्रेजुअल प्रोग्रेसिव एन्युलर प्लाक्स विद सेंट्रल स्कारिंग. बताओ सेंट्रल स्कारिंग कहाँ पे पढ़ा हमने? लूपस, राइट? सो दिस इज लूपस वल्गारिस. सो 3 सेंट्रल वाले याद रखना. Patchy hair loss, right temporal and occipital. So whenever they give you specific area, temporal, occipital, you can access. Non-scarring है, perifollicular hemorrhage है, अलग-अलग length के है, it is trichotillomania, right? So this is trichotillomania. Very mild infiltration. If you see swarm of bees, then alopecia areata. Okay. Oily skin with acne. देखो खतरनाक. Isotretinoin, nodulocystic. Okay, so this is isotretinoin. अगेन वेरी पैची, एक्सेसिबल जगह पे है, यंग गर्ल है, ट्रिकोटिलोमेनिया है इसको. ठीक है. एनेस्थेटिक पैच ऑन द राइट फोrearm, thickened nerve was palpable. Single patch thickened nerve. What is this? This is the first. All right, so you will see in leprosy class, this is the first thing, tuberculoid pole. Nerve for biopsy, this also you will see radial cutaneous nerve is preferred, followed by sural nerve. Okay, so RCN is the first.
multiple hypoaesthetic patches, multiple nerves are enlarged. What is the diagnosis? See, it can't be LL because in LL you will not see nerves enlarged. So multiple patches are, so it is lepromatous pole, but because nerves are also enlarged, this is borderline. Get my point? पढ़ोगे बाकी आपने जिनका नया लग रहा है, but this is why it is not LL. Okay, what's a benign, what's a, so HPV 611, right? Condyloma lata, condyloma acuminata. Condyloma acuminata. CL is going to be with secondary syphilis, mucus lesions. Okay. एचपी बॉडीज ही है, ये तो हमें पता ही है, हाईलाइटेड भी है, मोलस्कम कंटेजियोसम, अम्बिलिकेटेड लीजन्स, पॉक्स वायरस, oral candidiasis does not present with white patch. टेढ़ा सा क्वेश्चन, remember it is chronic atrophic candidiasis which does not present with white patch, बाकी सब में आता है. patchy hair loss, black dots है, so this is tinea capitis, grey black dot grey patch होता है, greasy of fulvin. स्केबीज तो मैंने क्या ही पढ़ा है, उसमें क्या ही होता है, बरोज होता है, यू ऑल नो राइट, सो देयर आर बरोज एंड देन इट विल गो एवरीवेयर, सो दिस इज स्केबीज. स्केबीज कौन पढ़ता है, 5% पर मेथ्रिन देना है, सब कुछ साफ करना है. एचआईवी पेशेंट, अम्बिलिकेटेड लीजन, इंट्रासाइटोप्लाज्मिक एचपी बॉडीज, ठीक है, नॉट इंट्रान्यूक्लियर, इंट्रासाइटोप्लाज्मिक आर एचपी बॉडीज. डन. Okay, so all you have to do, so homework is two things in the group. You will post two things, you will post leprosy ka link and you will post STD ka link. So today we are finishing off all of these. हमारा आधा डर्मा हो गया है for sure. Tomorrow we'll be doing vesicobullous pigment disorders and systemic disorders और कल डर्मा हो जाएगा. So today बस खाली इतना सा देख लो and then sleep, चैन की नींद, and tomorrow we'll finish off dharma. Okay, thank you so much guys and see you all tomorrow. Bye bye.